Yes.
Okay, thank you very much. Good morning, good afternoon, good evening. Thank you for allowing me this opportunity to share my experience with this probably seems to be very simple, very initial step of any cranial surgery. But for me, it's the most important step. If it is done correctly, then all the other steps can be corrected. But if this initial step is done in a wrong way, then just like the mathematics, the wrongness will be magnified more steps you are proceeded in your surgery. So my topic is the principles of head fixation in neurosurgical practice. The art of head fixation is considered as the initial, most important step in any successful cranial microsurgery. It should be done in a harmony and a coordinated fashion with the surgical approach and the patient's positioning. You have to take in consideration how you will approach and how you will position the patient. It is based on the knowledge in the anatomy, not only of the scalp, but of the skull, mostly the vowel, and the temporalis muscle and the suboccipital muscles. I have nothing to declare. Of course, there are two major systems for head fixation. The one that's most popular all over the world is the Mayfield head fixation, which is based on 3 points head fixation, as when you are holding an egg by your 3 fingers, so you can hold it in a very stable way. This was the physical principle of the Professor Mayfield when he designed the Mayfield head clamp. The other one that I prefer is the Sujita system, and it is based on the semicircle, putting the lesion in the center of this semicircle, just like in the stereotactic frame. This is the basic design of the Mayfield. All of us will be familiar. It's composed one side of 2 pins and one side 1 pin with a gauge that measures the pressure in all 3 pins. And the Sujita system, this is the head holder, and it is a semicircle. The inner diameter is 25 centimeters. There are 6 holes. You can put 4 pins, 5 pins, 6 pins, 3 pins, according to the pressure distribution that is desired by the surgeon. There are some minor modifications for the Mayfield system, for example, in this design, where it gives more room for the accessibilities to the cranium. And there is, of course, needless to say, the radiolucent one that is used when you want to use the intraoperative imaging. Regardless to the system, if you are using the head fixation system, whether it is Mayfield or Sujita, you have to fulfill 4 criteria, and I will speak in details about these criteria. First and foremost is the maximum patient's safety. Second, it should give you an optimum exposure of the surgical field. Third, it should provide you the maximum benefit and utilization of the accessories that are provided with each system. And fourth, it should be comfortable. It's not good to position the head in a way that is not comfortable to you. It should be ergonomically advantageous and best comfortability to the surgeon. So the maximum patient safety, there should be no risk of slippage. And it happens, surprisingly, in not rare situations. In about 10 to 15% of neurosurgical procedures, the slippage of the head can happen. And the FDA in 2016 urged caution with the neurosurgical head holders due to the slippage. That happened in more than 1,000 of the cases. And in 700, there is serious injuries happened to the patient. So you have to put it in a way to secure maximum patient safety. The most important thing is that to avoid skull fracture, to avoid extradural hematoma, and to avoid CSF leak or organ injury. Second, it has to give the best surgical exposure of the field. As you can see that always your field is in the center of the exposure in a maximum beneficial way. Third, you should use the accessories in the best possible ways. If the Mayfield is positioned in the inclined way, then you cannot insert over it the Bodo-Halo ring that is provided with the Mayfield in the majorities of the centers. The same thing with the Sujita. If you are not optimally exposing the patient, then you cannot use the accessories like the subframe, the patty trays, the retractor system, the springs. You cannot use it if you are not using it in a proper way. Also, it should be ergonomically comfortable, and by ergonomic, we mean that it is a human engineering that deals with the comfortability and the safety of the neurosurgeon. So you can see how you can sit comfortably, you have a hand rest, and you can sit in this way with the mouth switch and operate in this way. Probably it is not good. This is our giant, it's Professor Yezergil, but he is operated in this rather uncomfortable way. Of course, you cannot sit in these situations for hours. You can probably be in a few minutes. So you have to position the head. You have to use the Sujita or the Mayfield in a way to calculate the extremes of your exposure. Or like Professor Hernestimi, he used in this position, you have to avoid these extreme positions because they are ergonomically not advantageous. This is my experience, about more than 7,000 craniotomies. I did the majority utilizing the Sojita system. And I utilized these all 12 approaches that are utilized by most neurosurgeons. This is the initial description of the Sojita system back more than 40 years. And it is composed of this head holder, which is half a circle of 25 centimeters inner diameter. It takes in consideration all of the different sizes of the human heads. And as I said, the principle is to put the lesion in the center of the arc so that you can rotate and you can look to the lesion in different angles. In it, there is the multi-purpose frame, which is divided into the basal frame and into the subframe. What are the advantages of the Sojita? I had no incidence of slippage. The head can be rotated during surgery. Of course, you can substitute it by the rotation of the table. There is fixed, strong scale retraction. Probably this one is the most important advantage of the Sojita system. It can be used in all neurosurgical approaches, sitting, prone, semi-sitting, lateral. It is ergonomically very comfortable, and there is no incidence in my hands for the breakage in the head holders or in the pins. But there are certain disadvantages. The first one is that the holders of the springs might impinge in your hands when you come from the back of the patient. And this is not only my experience, it is also the experience of different surgeons. This is Professor Hernestimi. He also suffered from this disadvantage. Other disadvantage is that if you are using too many springs here, there will be a drift of the subframe. And the adapters, they are only on 3 different options, not more. In 2018, the Sojita 2 system had been released. All of the disadvantages of the Sojita 1 had been nearly overcome with the Sojita 2. The screws had been hidden so that it will not entangle with the wires or the sucker. There is a smooth surface, so it's not traumatic. And the adapters can be used anywhere. It is 360 degrees of retraction. And of course, there is no subframe drift. As you can see also, you can put the springs all over, wherever you want. Here, there are only six different positions of the spring holders. Here, you can use more than 6, and you can put it everywhere you want, even on this side, even on the other side. And also, they have changed dramatically. The designer of the retractor can be used in any direction. The pins, you have to know that there are 2 types of pins in both Sojita and Mayfield. There is a pediatric pin, and there is an adult pin. So the pediatric pin is a short, and the adult pin, never use in pediatric patient. Adult pin, I have incidents in one of my colleagues. He used an adult pin in a pediatric patient, and the result is CSF leak. Now, there are basic principles how to fix the heads. There are 4 basic principles. First, you have to choose which are the areas that can receive the pins, how to insert the pins, what are the skull equators in regard to head fixation, and how can I position the skin flap and craniotomy in regard to the head holder. This is from Neurosurgery book. These are the area, the shaded area, the yellow shaded area, are the areas that are receptive for the pins. And this is the sweat band, which is the area that's most suitable for the head pins. you have to avoid these areas. You have to avoid air cells, you have to avoid craniotomy or shunt, you have to avoid, of course, the temporalis muscles and the suboccipital muscles, and you have to avoid the main trunk of arteries and the nerves. So the main trunk of the superficial temporal or occipital artery, if you have CT angio, you can know at least where they are located approximately, and you should avoid putting the pins over them. The most important nerve, in my opinion, that should be avoided is the supraorbital nerve. I have a patient with severe pain in neuroma when the pin is inserted here. Now, how to insert the pin? This is different in Sogita and Mayfield. In Sogita, there is what's called the stable torque increasing ratio. Wherever you have stable torque increasing ratio, it means that your pin has a good purchase. It penetrated the outer table and it settled in the deploying middle layer of the skull when it has a stable torque increasing ratio. If there is unstable torque increasing ratio, it means that you penetrated the whole bone. While in Mayfield, it is different. There is a marker on the single pin side. When it is three lines, it means that there is 60 pounds. If it should not be exceeded more than 80 pounds. In pediatric, this is an adult patient. In pediatric patients, if he is below 5, then you can use up to 40 pounds. If he is above 5, then again, you can use up to 40 pounds. But in pediatric, you can use 10 to 40. And above 5 years, you can use 30 to 40. The thick hard bone, the parietal bone, almost all accepts the pins. The frontal bone, the frontal plates accept the pins. The occipital bone, this is important, above the inion can accept the pins, but below the inion, it's very thin bone, just like the temporalis bone that's covered by temporalis muscle. It cannot accept the pin below the inion. And all of the temporal bone are not accepting the pin except the upper part of the mastoid bone. Now the skull equators.
Please conclude.
Sorry?
Please conclude. Time is out.
I told by Professor Gongur that I have extra 10 minutes, if this is correct or not.
Yeah,
It's okay.
Because Sachin Chimate couldn't join, because of this, we gave more 7 minutes to Ahmed Adnan.
Okay, thank you very much.
Okay.
Thank you.
Thank you.
So the other principle is the equators. This is very important principle. The pins should crossing the equator or at the equator. There are 3 equators. Not all of them they are necessary in all positions, but the equator that is in concern with your position, you either should be on the equator or you are crossing the equator. It shouldn't be you are away from the equator. And this illustrates this concept. This is the axial equator. It's located from the inion up to 5 centimeters above the nasum. This is the axial vault equator. So the excellent is if you are putting your plane at the equator or crossing the equator. And this is wrong when you are putting it above the equator because there is a risk of slippage. Here you can see this is the equator that is important, which is the axial. I put the frame at the axial equator or crossing the equiaxial equator, but not above it or below it. Here you can see this will never slip, but this will slip because this is at the axial equator. This is above the axial equator. And this image is important that illustrates if you are putting the patient in the lateral position, then the sagittal equator is important. So you have to put your pins across the sagittal equator. It is not above or below the sagittal equator. Here there is a risk of slip, and here also there is a risk of slip. The pins has to encompass the sagittal equator. If your patient is in the supine position, then you have to be either at the coronal equator or crossing the coronal equator. It is wrong to be above the coronal equator, either crossing or at the level of the coronal equator. So this is correct because we are on the coronal equator. Here is the correct, here is the incorrect because here you are crossing the coronal, here all of your pins are outside the coronal equator, so there is high possibilities of slippage. Here is again, if you are in the park bench position, then the sagittal equator is important. If you are below it, or if you are above it, you are not crossing the sagittal equator, then there is possibilities of slippage or the fall of the head. The fourth principle is that your flap should be in the middle of the arc, regardless to the system, to have the best exposure. So in any flap that you are using, in any design of the craniotomy, whether linear, semilinear, the horseshoe, it should be in the middle of the arc to have the maximum beneficial exposure. Here you can see posterior interhemispheric approach. It is in the middle of the arc. Anterior interhemispheric approach, it is in the middle of the arc after taking in considerations the equators. Here is the retrosigmoid approach. Again, it is in the middle. The frame should not come here because it will obstruct your vision. Here is the standard trional, and as you can see, it is in the middle of the approach. Different approaches, you are on the middle. So in this way, you have a maximum exposure, and you have the best benefits of the use of the springs, of the Leila system, and of the patty trays or other accessories that you want to come closer to your field. Here you can see it is in the middle and maximum exposures. It will not interfere neither with the lighting nor with your hands. It's the same. Here I will demonstrate, and you can see it will take very little time. One of your hands should be folded like this. I'm doing the fixation by myself. This should be done a diagonal. Avoid the temporalis muscle. This is diagonal to the head. Insert these two pins first, and then insert the other one in a torque increasing ratio. As you can see that the incision is in the middle of the field, and we are crossing the sagittal, the axial plane. And then position it in this way. Your assistant should hold the neck of the patient. Of course, you need to put some antibiotic ointment on the pin's head. And then after that, you have to be sure, double check all the screws, and they are on the torque increasing ratio. There are no numbers on the Sogita. There is the torque increasing ratio principle. Double check everything. Complications. The one is the bleeding if the pins comes accidentally on the major arteries, and this might end with the small aneurysms that can rupture. You have to avoid these major arteries. The other complication is the nerve injury, and as I said, I had a case with the supraorbital nerve injury with resultant painful neuroma, and most importantly is the slippage and the skull fracture. So in conclusion, proper head fixation based on anatomical and functional concepts are initial but very important steps in the microneurosurgery. Patient's comfort and safety together with the surgeon's comfort are the goals of a proper head fixation and surgical approach. Sogita and Mayfield systems are very safe if they are used properly and effective in all neurosurgical approaches that we utilized. The skin flap should be in the middle of the head holder to have the maximum utility of the basal frame and the subframe, or the Greenberg-Budd-Halo ring in the case of Mayfield. The lesion should be in the isocenter of the arc. The axial, coronal, and sagittal plane should be considered, and injury can happen, and it is recorded in 700 cases in the FDA program. Thank you very much for your listening.